You look at this on a sagittal image of this on the topic of aortic arch, so it's a well-timed question, is what do these two cases have in common? So and it's a sort of a trick question, because if you actually look at these two, you can see the one in the right, there was actually concern on the three-vessel tracheal view with regard to the aortic isthmus at this point here, in which we are Z-scoring. But I'm asking you just to think outside the square. What is it about these two aortic arches that is a little bit unusual? Let me just say to you, I didn't comment on it because I struggled getting the aortic arch in that patient, but that's the left brachiocephalic vein. That's where the left brachiocephalic vein sits. That is not an aortic arch branch. So I'm just sharing this as a quick spot diagnosis. I'm not going to ask you to give me an answer. It's the next ones that I will. But this is actually a variation in arch anatomy that is actually quite common, because no matter what you do as you screen across this, you have a big juicy vessel here that ends off giving the innominate, the right common carotid and the left common carotid. And this is a bovine aortic arch. And both of those babies had a bovine aortic arch. And that is far more frequent than you think. And you haven't seen a bovine aortic arch in routine screening. Or in terms of fetal echo, maybe you haven't been looking close enough. This is a question which I would like to put forward, because it's a question maybe for, I think, Juleni. I'd like to maybe put this question, or start with Juleni, maybe Bev, I'd do the next one. This is a routine scan that you do in a baby in say a third trimester scan, and you find the presence of a flapping foramen ovale. And what I've done in this scenario of seeing a flapping of a foramen ovale is I've done an M mode to see whether the foramen ovale touches the left atrial wall. So, Juleni, in a scenario where you're doing a scan, ignore the fact that there is a little bit of ventricular disproportion here in this case, if we've got a microphone for Juleni, is in a scenario where you've got an entirely normal scan and you see a prominent foramen ovale as an isolated finding, do you disclose that to the patient, and do you recommend any postnatal evaluation or imaging?
So what's the gestation you said?
Let's say 32 weeks gestation.
And why was she referred to me?
Referred, let's say, as suspected muscular VSD, and there's no muscular VSD.
Okay. First of all, I just want to correct you on something when you put the M mode. It's not the foramen that's touching the left atrium, it's the flap valve of the foramen. The foramen is the hole, so the foramen doesn't touch the wall.
The foramen ovale flap.
Flap valve, so you've got flap, just a correction.
That's okay.
Now, if a patient is referred to me and I see there's a 32 weeks, I always, when I see something that's not what is the usual, I would always draw them 2 pictures of the normal heart, and I would describe to them what I can see on the scan. So I would describe what I can see about the disproportion. I can say, I would look at the aortic arch to make sure I'm happy.
The scan's completely normal, Juleni.
Then I would tell her that this is going to change after the baby's born, and I'll explain to her the physiology and pathophysiology behind that, if I'm entirely happy with the aortic arch. And I wouldn't do anything else if the arch is entirely normal. Okay. There's a bit of asymmetry, a bit of isthmal hyperplasia, transverse arch hyperplasia, which is not infrequently. You'd see, if you see this right-left asymmetry, at 32 weeks, I'll probably bring her back at 36 weeks, because I don't want her to worry about it.
Yep.
And then I would, if the arch is still, if there is some asymmetry, I would put in place some clinical assessment of the baby after birth.
You would, clinical?
Just to document. Yep. I think we're going through a phase where everyone is over-diagnosing coarctation based on disproportion. Yep. So there are lots of things that you have to look. I mean, there's a talk on coarctation. I don't want to preamble what's going to be discussed. But I think it's sometimes for the family, it's nice to have that closure, even if I'm 100% sure that if there is asymmetry, if the aorta is entirely normal, no, I wouldn't put anything.
Yep. I mean, Daria, would you like to comment on it? Because the other issues, the issues written prenatally, is the association of tachyarrhythmias.
Yes, not only that, but I was focusing on the fact that, as shown in your case, and we published that in the past, this situation may mimic entirely an aortic coarctation, because you do have right ventricular prevalence and ventricular disproportion that you showed in your image, And if you go on the transversal trachea view, in several instances, you have a mild to moderate discrepancy in size of the pulmonary ductal arch versus aortic arch. And on some rare occasions, you also have a reverse or turbulent flow across the aortic arch in these cases. And we have shown that this was related to the fact that the bulging of the flap of the foramen ovale obstructs the inflow to the mitral valve, so you get a redistribution of flow towards the right side of the heart. So the left heart structure are devoid of blood.
Yes.
And this leads to a smaller arch in most of the cases, but not at all an aortic coarctation. But still, this situation may mimic entirely an aortic coarctation, and the person scanning the patient in the referral center should be aware of this possibility of false positive diagnosis.
Yep. Dario's paper, which he's making reference to, is actually referenced on the very bottom of that slide, was published in the White Journal in 2020.
It's in my talk on ASD.
Oh, is it? Okay, sorry, Ravi.
No, because this is often a referral, ASD because of a large... I will have one.
No worries. Okay, so I'll finish with the last case. Now, this is an interesting case. It was a patient who was referred, you'll see just a couple of weeks ago, who was referred with tricuspid valve regurgitation. So just want to ask you what your thoughts are on that. So first of all, it's a very narrow box, as I was talking about earlier on. The descending aorta defines the left atrium, and therefore that's the right ventricle, that's the tricuspid valve. You're using Cineloop, and you're trying to decide exactly where does the jet arise from, and I'll be talking about tricuspid regurg later. And then you move on to a 2D sweep of the same baby, magnified image, a cardiac setting, increasing your dynamic range. And as you look at that, there's something unusual with regard to that four-chamber. Does anybody want to pass any comment of what are the points? There are 2 points to be concerned about on that four-chamber view of heart. Well, there's 3 points, actually. I mean, do you think that's... I'll start, maybe get the ball rolling. Do you think the cardiothoracic ratio is 50% or less? No. So we agree that the heart is sort of enlarged. The cardiothoracic ratio is probably more around 60-65%. Okay. My next question to you is there anything, or maybe you tell me, what's the thing that strikes you on the four-chamber? The tricuspid valve, yeah? The septum, okay. When you look at the septum, what happens normally during ventricular systole at the interventricular septum? What direction does it move? So if you look at towards from the left ventricular side, normally the interventricular septum will move towards the left. If you look at it, it's moving away. It's paradoxical motion of the interventricular septum. So the movement of the apical septum and the movement of the septum in the region of the AV valves is different. And then the next observation, which is a very subtle observation, and I think it's on the next clip, is Cineloop. And I want you to look at the septal leaflet of the tricuspid valve and then the mitral valve. They don't open at the same time. The tricuspid valve opens after the mitral valve. So I hope I have put the clip in. No, I'll put, but this baby's right ventricle, do you think it looks normal? The right ventricle's ballooned. This baby's got a right ventricular aneurysm. And with a right ventricular aneurysm, they get dilatation and they would get an appearance of a right bundle branch block. And with a right bundle branch block, you'll get delayed opening of the tricuspid valve and the mitral valve. And it's only when I looked at the Cineloop that I realized that they weren't opening at the same time. And then the color, after T, it's the first clip I'll show you the color. It was actually quite hard to demonstrate the color. But in a sense, the reason why the baby presented with tricuspid valve regurgitation was because of that dilatation, aneurysmal dilatation of the right ventricle that brought us to a diagnosis of a cardiac aneurysm. When I looked at the cardiac aneurysm, again, when we looked at the ECG afterwards, a cardiologist reported as widening. I can't read an ECG, but Bev and Jelani, I'm sure you can, looking at that, but there's widening of the QRS complex, which they said was very mild. But I read, looking at it, I said, oh my God, that's a horrible diagnosis to make in terms of a ventricular aneurysm carrying an absolutely terrible prognosis. But after birth, this baby has done quite well, in a sense, because they dropped their pulmonary pressures. The actual work and the load on the right ventricle is much less. And this baby actually, while admitted to NICU, who was only there for 2 days, and then literally 5 days later is discharged home. And hopefully next time I come back, I'll update you on how she's going. We might stop there for break time. And
what's the cause of this aneurysm?
well, if you look at differentials on it, I mean, it's probably more a question for the pediatric cardiologist, but my reading on it is either a weakness in the muscle itself or either no formation in Uhl's syndrome, where it's simply a fibrous tissue that forms the right ventricle. But the underlying mechanism where there's weakness in the muscle of the wall, Giuliani, I don't know if you want to add to the differential of that versus... Or Bev.
For Uhl's, normally you'd have thinning of the myocardium, which is not the...
Yes, I know, I just included the differential.
It's quite a generalized bulge, and the function is the most striking thing to me that was abnormal. So in that particular case, I would have looked at the duct as well, make sure there was no duct constriction.
Yep.
It was quite high velocity-ish on the tricuspid valve. But the aneurysms I've seen, I don't know if it's the cause, if you answer the question, but I've seen it sometimes in mothers who are diabetic. I've seen, for no reason at all, really localized large aneurysm, sometimes associated with Down syndrome. I've seen that as well. These are examples that I've seen. I'm not saying that is the reason why they have an aneurysm. And in terms of development, they usually get smaller with time. So that area doesn't get bigger with the heart, if that makes sense. So they tend to get smaller and smaller. They can, however, cause ventricular ectopy and ventricular bigeminy. So you just need to monitor.
Okay, so thanks very much, Giuliani. We might stop there and for a break. And if we come back, let's see. Yes.
Thank you all for a lovely first session. We're going to have a quick 15-minute break to get back on time. So if you can return back at 11:50. Thank you.
Great. Thanks, folks.
11.
you look at this on a sagittal image of this